Today's lecture is health indicators. The main concepts and principles that will be explored in this lesson are health status indicators, morbidity and mortality, crude and specific mortality rates, standardized and adjusted mortality rates, case fatality rate, perinatal neonatal infant mortality, potential years of life lost, life expectancy, natality, and indicators of health. An indicator is a single measure, usually expressed in quantitative terms, that captures a key dimension of health, such as how many people suffer from chronic disease or have had a heart attack. Indicators also capture various determinants of health, such as income or key dimensions of the healthcare system, such as how often patients return to hospital for more care after they are treated. Health indicators are standardized measures that permit comparisons of health status, health system performance, and characteristics among different jurisdictions. Health indicators provide comparable information to support provinces, regional health authorities, and health care facilities as they monitor the health of their populations and track how well their local health system functions. Indicators are also used to inform health policy, manage the healthcare system, improve our understanding of the factors that influence health, and identify gaps in health status and outcomes for specific populations. Morbidity. Morbidity is defined as any departure, subjective or objective, from a state of physiological well-being. In practice, morbidity encompasses disease, injury, and disability. It can also be used to describe the periods of illness that individuals experience or the duration of illness. Measures of morbidity frequently characterize the number of persons in a population who become ill, incidence, or are ill at a given time, prevalence. Mortality. In contrast, mortality focuses on understanding and measuring deaths. Mortality rate. An estimate of the proportion of a population that dies during a specified period. The numerator is the number of persons dying during the period. The denominator is the number in the population, usually estimated as the mid-year population. This rate is also called the crude death rate. The formula for calculating the mortality rate is mortality rate equals number of deaths in a given time period divided to population in which deaths occurred in a given time period and multiply to 1000. Recall that a rate always has an element of time. When the mortality rate is based on vital statistics, such as death certificate date, the denominator is usually the population at the midpoint of the given time period. Crude and specific mortality rates. In general, there are two different kinds of rates, both of which can apply to mortality, crude and specific rates. Crude rates. Crude mortality rates include in the numerator all events, in this case deaths. The denominator represents the total population from which these events arise. For example, a crude mortality rate can be represented by mortality rate, all death in country, for example in 2018 year, divided to mid-year population of country in this year and multiply 10n. Specific rates. Specific rates are, as the name implies, specific to one group. The numerator is limited to one group. It may be age, sex, linguistic, or any other group with a common link. The denominator represents only the population from which the numerator is drawn. For example, an age-specific mortality rate can be represented by all deaths among 25 to 34-year-olds divided to mid-year population of 25 to 34 years olds in this city and in this year. With a cause-specific mortality rate, the numerator refers to deaths from a specific cause. No, we will talk about myocardial infarction. However, the denominator represents the total population, as the deaths in the numerator come from the total population and the whole population is theoretically susceptible to myocardial infarction. Cause-specific death rates approximate the risk of death from a specific condition, one of the most important epidemiologic indices available. The cause-specific mortality rate for myocardial infarction can be represented by all deaths from this disease in the certain city in the certain year divided to mid-year population of this city and in this year. Example. An example of a cause-specific death rate Алекс, приходите, садитесь.
Вот зачет.
Зачет через час подойдите. Да. Canadians died due to suicide and self-inflicted injury, resulting in a cause-specific mortality rate. Combinations of specific rates. Mortality rates can be further refined by combining cause-specific, age-specific, and/or sex-specific rates. For example, the mortality rate attributed to opioid overdose among 25 to 45-year-old males in Canada would be a combination 3 mortality rates. First is cause-specific. Second, age-specific. And sex-specific. In this case, it is opioid overdose, cause-specific, age-specific, 25 to 44 years old, and sex-specific, males. Reflection checkpoint. So what is the expression for the numerator of the mortality rate for the above example? Try to answer this question yourself. And the next question is, what is the expression for the denominator of the mortality rate for the above example? Answers on these questions. So the first question, what is the expression for the numerator of the mortality rate for the above example? Answer, number of opioid-related deaths in males between the ages of 25 and 44 in the year of interest in Canada. And answer on the second question, what is the expression for the denominator of the mortality rate for the above example? Answer, total male population between the ages of 25 and 44 in the same year of interest in Canada. Here you can see an example. This graph shows age and sex-specific mortality from accidents. Unintentional injuries. On previous lesson, we told about standardized or adjusted rates. Comparison of rates between populations often yields useful information for public health. Of course, like must be compared with like. One way to do this is to break data down to age and sex-specific rates and then compare. But this is not always practical. The specific rates may be too small to rely on, or they may be too many rates to allow for interpretation. A summary measure is needed in these situations. However, any comparison of crude rates between two or more populations is likely to be misleading because the populations may vary considerably in their underlying age distributions, as we saw in these population pyramids from previous lesson. It would not be like with like. As you remember this pyramid, compare 2 years. Здравствуйте. For example, comparing the crude mortality rate for a retirement town comprising a large seniors population to the crude morbidity rate of a college community with a younger population will not yield useful information. Is there a way to get around the problem of comparing two different populations while still obtaining usable information? There is. Published morbidity and mortality rates are often presented as standardized or adjusted rates. Standardization or adjustment is a statistical way of removing the effects of differences in the composition of the populations. This is done by weighting or assigning values to the rates for different populations to render them more similar. Each population under study is mathematically adjusted to reflect the age distribution of an outside third, otherwise known as a standard population. Standardization is not always required. Crude rates are recommended when a summary measure is needed and it is not necessary or desirable to adjust for other factors. For example, rates of infectious diseases such as tuberculosis are usually not age adjusted because public health officials are interested in the overall burden of disease for the total population, irrespective of age. Age standardization, a procedure for adjusting rates, death rates, designed to minimize the effects of differences in age composition in comparing rates for different populations. The standardized rate represents what the crude rate would be if the population under study had the age distribution of a standard population. It is the weighted average of age-specific rates applied to a standard distribution of age. It is used to compare incidence rates of illness or a health condition between populations with different age distributions. Age standardization is a statistical procedure that results in age-adjusted rates. Age-adjusted rates can be thought of as what would the rate of X in this population be if it had the same age structure of that other population. It can be possible to take one population age structure and use it as the reference or standard against which many other populations are compared. Using this, you can compare many populations at the same time. For example, you could standardize the mortality rate of all 10 provinces using the all Canada population age structure. Once provincial rates are calculated with the same age structure, you can compare between each province as well. Standardized rates can only be compared if each is related, standardized to the same reference population. Age standardization takes some effort, but once rates are converted to a theoretical standard, you can make many comparisons easily. It also does not usually matter very much what is chosen at that reference or standard population. If lots of people agree to the same standard, then many rates can be compared to each other easily. Using one standard population consistently allows for comparisons over time. In public health settings, the 2011th population is a frequently used standard population in reports. In other words, an age standardized incidence is the incidence rate that a population would have if it had the same age distribution as the 2011 population. Example. Consider the breast cancer incidence rates for different cities, Ontario and Alberta. The crude rates are 109.7 to 1,000 for Alberta and 135.8 to 1,000 for Ontario, a difference of 26.1 to 1,000. Breast cancer is more prevalent in older women. If one province has a greater number of older women, it will of course have a higher rate of breast cancer. Can these rates be compared? Answer: no. The age standardized incidence rates for breast cancer in the first year are 96.7 for Alberta and 105.9 for Ontario, a difference of only 9.2 as compared to a difference of 26.1 found when crude cancer incidence rates were used. Next, case fatality rate. Case fatality rate is the proportion of cases of a specified condition that are fatal within a specified time. A case fatality rate measures the proportion of all people with a disease who die from the disease. In other words, it measures the likelihood that a disease will kill its host and is thus as an important indicator of the severity of a disease and its significance as a public health problem. Since the case fatality rate is a proportion, it is expressed as a percentage. The formula for calculating the case fatality rate is case fatality rate equals number of deaths from a disease in a given time period divided to number of diagnosed cases of the disease for the same time period multiply 100. Example: in town A, 16 cases of breast cancer have been diagnosed over a 2-year period. Of these, 3 have died. The case fatality rate for breast cancer for that 2-year period is 3 breast cancer deaths divided to 16 cases of breast cancer and multiply 100. 3 divided to 16 multiply 100 equals 18.75%. The recent Ebola virus disease outbreaks in West and Central Africa demonstrate the variability of case fatality rates. Over time and between countries, the case fatality rate for Ebola virus disease has ranged from 25% to 90%. The World Health Organization estimates the average case fatality rate for Ebola virus disease to be about 15%. Perinatal, neonatal, and infant mortality. When you are calculating these indicators, you can use these formulas. Neonatal mortality rate. In numerator, it will be number of deaths under 28 days of age during a given year. In denominator, it will be number of live births during the same year. Infant mortality rate. Number of deaths under first year of age during a given year. In denominator, it will be number of live birth reported during the same year, and perinatal mortality rate in numerator, it will be number of fetal deaths, 28 weeks gestation, plus infant death less than 7 days of age in a given year. And in denominator, it will be number of fetal deaths plus live births during the same year. Perinatal, neonatal, and infant mortality are important measures for a population and reflect access to antenatal care and healthcare services in a community. Levels of these indicators are very different from previous years and nowadays. If we compare infant mortality rate in 1926 year, about 1 newborn out of 10 died in their first year of life. In 2018, the infant mortality rate for Russia was 7.23 per 1,000 births. For Canada, it was less. It was 4.7 deaths per 1,000 births. So you can see how infant mortality rate changes. Although low, infant mortality could continue to decline. For example, in Japan or Sweden, infant mortality is lower, 3.5 per 1,000 births. Then in Canada and then in Russia, it is lower, showing that improvements can still be made. Potential years of life lost. Mortality alone does not provide a full picture of how different diseases affect population health. Duration of life, combined with some notion of its quality, is reflected in various population measures, including potential years of life lost. The impact disease has on a population is an important factor in guiding decisions about which diseases to try and prevent. An obvious measure of impact is the number of deaths a particular disease causes. In Russia, this measure identifies heart disease, cancer, and stroke among those with the greatest impact. Mortality of heart disease is on the first place, and cancer is on the second place. However, these conditions tend to kill people who are reaching the end of their expected lifespan, so preventing them might have little effect on extending overall life expectancy. Preventing premature deaths would add more years of life to individuals and to society. Premature death can be defined in terms of death occurring before the average life expectancy for a person of that sex, now normally 75 to 80 years. With this idea, people who die prematurely lose years of potential life. And one way to judge diseases in terms of their impact on a society is to rank them in terms of the total potential years of life lost due to each. Priorities from the potential years of life lost will differ from those based on simple mortality rates. A measure of the relative impact of various diseases and lethal forces on society. Potential years of life lost highlights the loss to society as a result of youthful or early deaths. Because of the way in which potential years of life lost is calculated, the earlier in life a death occurs, the more weight impact it will have. Potentially avoidable mortality. The concept of potentially avoidable mortality has been constructed based on the knowledge that certain deaths can be avoided by either preventing disease or by preventing or delaying death once a disease or condition has developed. Mortality from potentially preventable causes refers to deaths that can be avoided by preventing a disease from developing. This includes death from conditions linked to modifiable risk factors such as smoking or excessive alcohol consumption, lung cancer, liver cirrhosis, and deaths linked to effective public health interventions, vaccinations, traffic safety legislation. Mortality from potentially treatable causes refers to death from conditions where it is expected that death can be avoided or delayed by measures such as screening, early detection, and appropriate treatment. Breast cancer, appendicitis. Life expectancy. Life expectancy is the average number of years an individual of a given age is expected to live if current mortality rates continue to apply. Life expectancy is a hypothetical measure and indicator of current health and mortality conditions. It is not a rate. Life expectancy is a widely accepted universal indicator of the health of a population. It is calculated from life tables that are constructed from current age and sex-specific death rates, assuming that these rates will remain unchanged over the life of the individuals in the population. This is not the case in practice, since death rates do, in fact, change. In general, life expectancy is most commonly presented as the average number of years of life an individual is expected to live from birth. However, life expectancy can be calculated from any age. It is the average number of additional years a person of age X will live. For previous year, 2020, in Russia, life expectancy at birth was 66.5 years for men and 76.4 years for women, a gap of approximately 10 years. However, this is an average for the whole population, and there are certainly differences among these two groups for many important factors, such as social determinants of health. Natality. Natality refers to births. In epidemiology, natality measures are used mostly in the area of perinatal and child health. Three of the most frequently used natality measures are summarized below. Вы зачетки оставьте. Один кто-то, один. Один кто-то. Ручку. Ручку.
Ручку.
Crude birth rate. Summary rate based on the number of live births in a population over a given period of time. Все, попозже зайдете, через 5 минут.
5 минут?
Usually 1 year per 1,000 people. Crude birth rate is calculated number of live births reported during a given year divided to estimated total population at mid-year and multiply 1,000. Crude fertility rate. A more refined measure of fertility than the crude birth rate. The denominator is restricted to the number of women of childbearing age. Childbearing age is from 50 to 44 or from 15 to 49. 15 to 44, 15 to 49. So, number of live births reported during a given year divided to estimated number of women age 15 to 44 or 15 to 49 at mid-year, multiply 1,000. Crude rate of natural increase. A measure of population growth in the absence of migration, comprising addition of newborns to the population and subtraction of deaths. Alternatively, it is the difference between the crude birth rate and the crude death rate. Number of live births minus number of deaths reported during a given year divided to estimated total population at mid-year, multiply 1,000. So, indicators of health. As noted earlier in this lecture, many indicators used in population health status assessments describe disease and death rather than health. Such indicators do not provide a sufficient base for effectively assessing population health status and determining public health priorities in countries like Russia with chronic disease patterns and long life expectancies. It is important to understand how individuals in a population can avoid being at risk for adverse health events and how much disability it presents in a population living in an era where chronic disease predominates. Indicators are required for measuring quality of life and quantifying the number of healthy years lived rather than just years lived. And examples of other health indicators include health adjusted life expectancy, disability free life expectancy, healthy life expectancy, active life expectancy in good perceived health, social determinants of health, and self-reported well-being. Так, now let's check presence.